Hi everyone, I'm Dr.M.Subbiah. Today I'm going to discuss clinical practice guidelines on Cerumen Impaction, that's the Airwax Impaction. So the target patient for this guideline is over 6 months of age with a clinical diagnosis of Cerumen Impaction. So Cerumen or Airwax is a naturally occurring substance that cleans, protects and lubricates the external auditory canal. It's a hydrophobic, waxy substance that provides mechanical and microbial protection to the epithelial lining of the external auditory canal. Normally, cerumen is expelled by a self-cleaning mechanism which causes it to migrate out of the ear canal assisted by jaw movement. Cerumen accumulates when this cleaning process becomes compromised through regular use of cotton-tipped swabs, digital manipulation of the ear canal, or use of hearing aids, all of which can pack cerumen deep into the ear canal. The patients with cerumen impaction can present with symptoms like oral fullness, hearing loss, ear pain, itching, tinnitus, and otitis externa. So there are four main factors that lead to cerumen impaction. One is overprotection. If the rate of cerumen protection exceeds the rate of cerumen migration out of the ear, cerumen impaction will occur. Second is obstruction. Variations in the anatomy of the ear canal, like congenital stenosis of the ear canal, can lead to cerumen accumulation. Inadequate epithelial migration. Cerumen glands progressively atrophy and become less numerous with age, so resulting in drier cerumen. So this drier cerumen is less readily transported by the epithelial conveyor mechanism. And fourth is cerumen phenotype. Cerumen can be divided into two genetically determined phenotypes, dry and wet. Then if cerumen accumulation has become symptomatic or prevents needed assessment of the ear canal or tympanic membrane, it is considered to be impacted. Cerumen impaction is diagnosed by doing otoscopy. So primary prevention. So clinicians should explain proper ear hygiene to prevent cerumen impaction when patients have an accumulation of cerumen. So ear candling or coning for treating or preventing cerumen impaction is contraindicated. So what is ear candling? It is the practice of placing a lit cone-shaped candle into the ear. So air candle is a hollow cone-shaped piece of cotton soaked in beeswax, paraffin or a mix of the two. The candle is about 10 inches long. So it's a form of alternative medicine that has been practiced for thousands of years. The heat from the candle is supposed to pull up the earwax. Wax is not dripped into the ear. Management. So prior to cerumen removal, potential contraindications must be identified. These include non-intact tympanic membrane, exostosis, ear canal stenosis, diabetes mellitus, and anticoagulated or immunocompromised state. Non-intervention if asymptomatic. So clinicians should not routinely treat cerumen in patients who are asymptomatic and whose ears can be adequately examined. So recommended interventions commonly used for cerumen removal are cerumenolytics, irrigation and manual removal. Cerumenolytic agents are compounds used to break down impacted cerumen to lessen the need for irrigation or manual removal. So cerumenolytic agents exist in three forms. One is water based, second is oil based, third is non-water, non-oil based. So water-based agents have a cerumenolytic effect by inducing hydration and subsequent fragmentation of corneocytes. Aqueous acetic acid, sodium bicarbonate and sterile saline solution are water-based cerumenolytics. Oil-based preparations are not true cerumenolytics. They lubricate and soften cerumen without disintegrating cerumen. Oil-based cerumenolytics are almond oil, olive oil and mineral oil. Non-water, non-oil based cerumen are choline salicylate and glycerin. The conclusion of a Cochrane review of water-based and oil-based preparations concluded that no specific agent was superior to another and none were superior to either saline or water. Irrigation. So gentle irrigation with a syringe is commonly performed and it's an effective method of cerumen removal. Oral irrigation should be avoided in patients with perforated tympanic membranes or meningotomy tubes, previous ear surgery, anatomic abnormalities of the ear canal. And care should be taken when treating immunocompromised patients, as invasive otitis externa has been reported in diabetic patients following oral irrigation. Why does it occur? Cerumen is acidic and normally coats the walls of the ear canal, thereby it inhibits the growth of bacteria and fungus. The elimination of cerumen raises the pH and along with the introduction of water can predispose vulnerable patients to develop otitis externa following irrigation. So reacidification of the canal with 2% acetic acid can help prevent colonization by the bacteria that can cause otitis externa and malignant otitis externa. So manual cerumen removal uses instruments to remove cerumen under direct visualization. This method of cerumen removal is considered to be safe and effective in the hands of a well-trained practitioner, but it can lead to trauma in less experienced hands. So manual cerumen removal is often preferred in patients with congenital or acquired abnormalities of the ear, those who have recently had ear surgery and immunocompromised patients. So what are the risks associated with manual removal? Perforation of the tympanic membrane, ear canal trauma, vertigo and pain have been reported following manual removal of cerumen. So conclusion, as no cerumenalytic agents have been shown to be more effective than water or saline, water and saline is recommended as first line agents. So these are the references. Thank you.